Hello, good evening, everyone. It's a great pleasure to welcome you all for this very exciting scientific webinar COUS 7 Treatment and Management of Breast and Lung Cancer. Now, it's great pleasure to invite Dr. Rajat Bajaj. He is a senior consultant medical oncology, Fortis Hospital, Noida. To welcome an introduction note, it's over to you, sir.
Yes. Yeah, good evening, everyone. I thank you all for joining this evening on this day 2 of the breast and the lung cancer updates that we are doing. Yesterday, we spoke about the lung cancer updates, and it was an insightful discussion between various speakers talking about what is new in the management of lung cancer, starting from the EGFR mutation to the ALK positive status to the immunotherapy that we are doing in metastatic lung cancer. Now, in day 2, we are going to talk about the hormone receptor positive breast cancer. Going to talk about the triple negative. We are going to talk about the HER2 positive as well. So, we'll be starting with the first talk being from the learnings of the recently concluded SABCS. And we have chosen two studies to talk about. One is going to be the Emerald study, and the other is the TAILORx study update. So our first speaker of the evening is Dr. Srijna Joga from Rajiv Gandhi Cancer Hospital. She is going to speak about what the learnings of the Emerald study, which was presented in SABCS in 2022. Dr. Srijna, good evening, welcome, and over to you.
Good evening, sir. And thank you so much, Dr. Rajat sir, for giving me this opportunity to present in this conference. So shall I share the screen?
Yes.
Is it visible now?
Yes, it is visible.
Yes, sir. Yes, ma'am.
So putting and are my slides moving?
No, ma'am.
Okay. Now?
Yes, ma'am. It's moving.
It's moving. Yeah. So good evening, one and all. So I would be speaking about the Emerald trial, which has been presented in SABCS 2022 in the metastatic breast cancer hormone positive HER2 negative, where the trial, it is a phase 3 done in patients who are hormone positive HER2 negative with elacestrant, that is the oral SERT, versus the standard of care endocrine therapy. And here the results of the updated PFS by the duration of the prior CDK4/6 inhibitor duration were presented. So coming to the background of the study, so as we all know, from 2015 onwards, the standard therapy in the first line for metastatic breast cancer in the hormone positive setting is the dual agent, that is the CDK4/6 inhibitors along with the endocrine therapy, that is depending on the hormone resistance, be it letrozole or fulvestrant. But eventually, one of the after patients have been exposed to the hormones, they develop resistance, and the most common method pathway of resistance is the estrogen receptor mutation, that is the ESR1. So after the first line, we are in a dilemma whether to go for the sequential monotherapy or in the combination therapies. When we have the SOLAR-1 trial, where we have a PIK3CA mutation, we give a combination of alpelisib and fulvestrant, and thereafter there are the options of everolimus exemestane, but these are toxic drugs to tolerate. Even though there is some oral combinations available, the patient has a lot of oral ulcers with the everolimus, and with alpelisib, the rash and the diarrhea and the hyperglycemia are very toxic. And overall, giving a fulvestrant injection every monthly and IM injection is also painful to the patient. So there is a significant unmet need for the oral therapies in the next line for these patients. So with this combination, the oral SERD therapy was explorated, And one of such drug is the elacestrant, which is an oral SERT, which demonstrated a very significant improvement in PFS in the heavily pretreated population in the phase 1 trials. So accordingly, this phase 3 trial was conducted in patients who were exposed to prior CDK4/6 inhibitors, which is the unique aspect of this trial. So the patients were stratified according to the ESR1 mutation status and whether metastasis visible mets were present or not, and prior exposure to fulvestrant. And the primary endpoint for this trial is PFS in all comers and the PFS in the ESR1 mutant population. So this this slide summarizes the previous slides, that the inclusion criteria were males and postmenopausal women who were hormone positive, HER2 negative, metastatic, and who received 1 or 2 lines of endocrine therapy and 1 line of chemotherapy was allowed in these patients. And overall, and those who have been given CDK4/6 inhibitors also. So the dose used with elacestrant is 400 mg daily versus the investigator of choice, be it fulvestrant, anastrozole, letrozole, exemestane, depending on the prior therapy exposed. And we have discussed the primary endpoints of this trial. So the baseline characteristics were well matched. When we see here, only 6 males in the elacestrant group and one male patient was incorporated into the standard of care arm. So there are very few male breast cancer patients, and most of them were females, and majority of them having ECOG performance status of 0 to 1, and everyone has been exposed to CDK4/6 inhibitors, which is the standard of care today. And almost half of the patients have received 1 or 2 1 line of endocrine therapy, and another half received 2 lines of endocrine therapy. And the most common used prior hormone therapy is the AIs. And very few patients received prior chemotherapy, around 20% of the population. So when they assess the progression-free survival by the duration of the CDK4/6 inhibitor, which the patient was exposed previously, be it 6 months or 12 months or 18 months, they have seen that the larger the duration and the more the duration of the exposure to CDK4/6 inhibitor, the elacestrant benefit was more. As we can see, the curves are getting nicely separated at the end of 18 months with the elacestrant as compared to the standard of care therapy. And when done a subset analysis of this PFS by ESR1 mutant population also, the benefit magnitude of benefit is still more. The hazard ratio is here just 0.4, whereas in the previous in PFS in all comers, the hazard ratio comes to around 0.7, that is 30% reduction in the risk of progression, whereas in the ESR1 mutant population, the reduction risk progression is just 45%. It's almost increased by 15%. So these are the slides showing the same things in a larger way. The PFS by 6 months is 2 versus 1 month median PFS, as at the end of 12 months, it increased to 8 versus 9 months in the standard of care arm, and at the end of 18 months, 5 versus 3 months with a hazard ratio of 0.7. This is PFS in all comers. This is the same slide explaining the PFS by CDK4/6 inhibitor duration from less than 6 months exposure, 6 to 12 months, 12 to 18, and more than 18 months. So median PFS is around 5.45 months with elacestrant as compared to 3 months with the standard of care arm. Whereas in the ESR1 mutant population, elacestrant, the PFS is 88 months in opposition to 2 months in the standard of care arm. So, to summarize, these patients, in all patients, PFS by the duration of CDK4/6 inhibitor, who have been exposed for at least 12 months, the PFS has improved 3 months. The median duration is 3 months versus 1.9 months with a hazard ratio of 0.61. Whereas in the those who have been exposed to at least 18 months of prior CDK4/6 inhibitor, the duration of PFS is 5.4 months. Whereas in the ESR1 mutant population, exposed population, it's 8.61 months versus 2.1 months. So the safety data results, the most common side effect associated with this drug is nausea, and the grade 3 events were 2.5% observed in 2.5% population. So to conclude, this is the only pivotal 100% prior population who have been exposed to CDK4/6 inhibitors. In the second and third line setting, this is the trial which gives us the answer to which drug can be used. And the duration of CDK4/6 inhibitor was associated with increased PFS in this trial. The longer the duration, the longer the PFS. Especially the PFS is prolonged in the population who are having the ESR1 mutant population. Mutant. And no new safety signals were identified, and nausea is the most common side effect. And antiemetic usage was low in both the drugs, 8% in the elacestrant and 10% in the AIs. So this showed that prolonged PFS was standard of care with a very low grade of adverse events. So this trial gives us an important oral endocrine monotherapy, which is the need of the hour in second and third line settings, because already the patient has been used to taking 2 years of oral therapy, and they'll be keen on taking oral drugs only with relatively less side effects. Thank you.
Okay, thank you, Dr. Srijna, for this very nice presentation on the use of SERDs in second line post the use of CDK4/6. So, do you think that your patients also don't like the fulvestrant therapy because it is intramuscular and it causes a lot of local side effects in terms of painful buttocks? The patient has to come every month. All these are issues which you also face in your practice?
Yes, sir. So most of the patients will be very unhappy thinking of the term injection, and they'll be asking still how long we have to take that.
Yes. So if the oral drug is available, it will definitely be a better choice. And of course, with the scientific evidence also being in favor and a better PFS being shown, I think if this drug is available, it will be our go-to second line therapy. But as of now, it is important to understand that the US FDA has still not approved it. It is under the priority review. And in the next few months, the jury will be out as to whether it gets approved or not. But certainly an important data set that one has to understand. Right. Thank you so much. So now we move ahead and talk about the second paper that we are discussing, which is the TAILORx study. We have had an update of this study, the 11-year update of this study. And to present this, we have with us Dr. Mohit Saxena from Narayana Hospital, Gurugram. Dr. Mohit, good evening. Over to you.
Good evening, sir. Thank you, Dr. Rajat, for giving me this opportunity. May I share my screen?
Yes, please do.
My slides visible now?
Yes, it is visible.
Okay. And they are moving?
Yes, yes.
Okay. So today we will discuss about TAILORx, that is trial assigning individualized options for treatment, and update including 12-year event rates. This is what we discussed in the Best of SABCS 2022. So we all know that there is a unmet need, that we want to know that for the good biology patient, that is hormone positive, HER2 negative patient, where we can skip chemotherapy. That's the aim. And for this, the Oncotype DX was the 21 gene difference score signature was done. And it was TAILORx trial was designed to identify that where we can think about skipping chemotherapy. So this was the trial design that is accurate between April 2006 and October 2010. The key eligibility criteria were ER positive and HER2 negative patient. No negative patients were taken. T1C and T2 high risk T1B, that is grade 3 patients, were also taken. And based on Oncotype DX, they were divided into the recurrence low, that is 0 to 10 in arm A. They were treated with endocrine therapy only. The mid range, that is 11 to 25, that is the most important, we will talk about in the next slide. And they were randomized into experimental arm B, that is treated with endocrine therapy alone. They have skipped the chemotherapy in this arm. And the arm C was standard arm, where they are treated with both endocrine therapy as well as chemotherapy. And number you can see, more than 3,000 patients were treated. ARMD was, of course, the high risk, that is 26 to 100 recurrence score. And there, of course, we can't escape chemotherapy in those patients. So they were treated with endocrine therapy as well as chemotherapy. So what is new in this updated analysis? Where we found that more than 50% recurrences develop after 5 years of diagnosis. That's the behavior of hormone positive and HER2 negative breast cancer. We can find the late recurrence. It is sharp contrast to the triple negative, where we usually found recurrence in initial part of the follow-up. That is within the 5 years and more in the 2 years. And as we know that the follow-up was, median follow-up was for 7.5 years for overall population, but for this specific group, that is RS 11 to 25, there was follow-up of 11 years available. And what we found that recurrences were 50% more. You can see that if the key endpoint, that the invasive disease-free survival, that is any recurrence plus secondary, primary plus death. So in the original, that is 836 event, but now it is 1,295. So almost it is 50% more. That is 1.5 times. And the same story for the DRFI, that is distance recurrence free interval, the recurrence free interval, and the overall survival. So more events were found, and when we followed for the almost 12 years. And we can see this in the graph, that is invasive disease-free survival. That is whether we treat with endocrine therapy or chemo plus endocrine therapy. There is not many difference. You can see that both of the lines are overlapping, and the hazard ratio is 1.08 at 12 years. The p-value is 0.19. That is not significant. The same story for the distant recurrence-free survival. Again, the hazard ratio is 1.11 and p-value is 0.34. That is not significant. So endocrine therapy is as good as chemotherapy plus endocrine therapy, even after 12 years. The same story for the recurrence-free survival. That is the hazard ratio of 1.15 with p-value of 0.12. Again, not significant. And the overall survival, that is the hazard ratio of 1.06. That is p-value in 0.46. And all these parameters shows no significant difference. So we can safely think about skipping chemotherapy, but not for all patients. We'll discuss in the later slide where we can skip. So in the what is new in this updated analysis, that is the recurrence, distant recurrence were around 7% at 12 years. That is, you can see the distant recurrence-free survival is almost 93% at 12 years in both arm B and arm C. It is irrespective of chemotherapy use. And there are almost 0.5% distant recurrence per year. And of course, the late recurrences exceed earlier recurrences. What you can see in the recurrence-free survival, that is, it is 97% at 5 years, while it is 90% at 12 years. So more recurrence after 5 years. The non-recurrence event, that is seen in almost 13%. That is, the recurrence-free interval was almost 90% and the at 12 year, and it is 77%. The distance-free survival was 77. So the difference is almost 13%. And overall survival rates were similar. So you can see that for all these endpoints, that is invasive disease-free survival, distant recurrence-free survival, recurrence-free survival, and overall survival, arm B and arm C are matching, and it is the same story which we have seen that 5 years is reduplicated at 12 years. That is, the hazard ratio is of almost 1. And what we see that recurrence score is almost prognostic as well as predictive. Of course, the arm A, that is arm A is showing higher disease-free interval survival in comparison to arm B, C, and arm D is, of course, that is with the high recurrence score is showing the least survival. And again, curve B and C are overlapping. The same story for the distant recurrence-free survival, again for the recurrence-free survival, and for the overall survival. The same story is there. So now we will talk about that what we want to know with this trial. Now they're showing in the score that is 11 to 25. They are divided into 3 groups: 11 to 15, 16 to 20, and 21 to 25. And what we have seen that you can see in the graphs as well, there is the yellow bar is showing for treated with the endocrine therapy, and green bar showing the treated with the endocrine therapy plus chemotherapy. So no benefit for 11 to 15, that's quite clear. There is marginal benefit in the 16 to 20 arm for both the invasive disease-free survival and distant recurrence-free interval. and there is evident benefit in the 21 to 25. That is, so these are the patients where we can't skip chemotherapy, and the 11 to 15 we can skip chemotherapy. What is important is the 16 to 20 group. Now whether we should offer chemotherapy or not. So they have tried to clarify in the next slide. What they have seen that they have included updated analysis. They have seen the effect of age, recurrence score, and clinical risk. Now, what we have seen that if the age is more than 50, then the chemo endocrine therapy is as good as chemo plus endocrine therapy. But if the age is less than 50, then you can see there are more of on the right side. That is, chemo is better, but not for the all patient. If the age is less than 50 and the recurrence score is the age is less than 50 and the recurrence score is 11 to 25, then they have divided that if the recurrence score is 16 to 20, and if the clinical risk is low, then the absolute benefit of chemo is only this minus 0.5%. So chemo is not beneficial. But if it is clinical risk is high, then the absolute benefit of the chemo is 3.1%. If the recurrence score is 21 to 25, then the absolute benefit of chemo is 5.9% for low clinical risk and 11.7% for high clinical risk. Now, what are these clinical risks? These are the clinical risks based on the MINDAC trial. That is 3, 2, 1. That is patient with 3. So they have taken size, and if there is and grade. So if less than size should be less than 3 centimeter for low grade, less than 2 centimeter for intermediate grade, and less than 1 centimeter for high grade patients. So that's how these are the low risk patient, low clinical risk patient, and rest are the high clinical risk patient. So we can see that if the recurrence score is 16 to 20, age is less than 50, but still the clinical risk is low, then we can think about skipping chemotherapy. Now, the race difference that in the initial analysis up to the 5 year, what they have seen that Black patients having more recurrences. So they have there was hazard ratio was 1.66 or 2 range for the disease-free survival, distant recurrence-free survival, recurrence-free interval, and overall survival, both for the unadjusted and adjusted. But this was not true after 5 years. Say if the analysis was in 6 to 12 years, then later recurrences were same. That you can see that hazard ratio is almost 1 and the p-value is not significant. So the difference of race is not appreciated after 5 years. So this is the conclusion from the updated analysis. The longer median follow-up and more events in the randomized group, that is median was 11 years versus 7.5 years. More event, that is invasive disease-free survival, that is 1,295 versus 835 events. And for the distant recurrence, it is 375 versus 250 events. Main study findings remain unchanged for recurrence score 11 to 25. That is the primary objective, that endocrine therapy is non-inferior to chemo plus endocrine therapy for invasive disease-free survival, that is the primary endpoint, and distant recurrence-free survival, that is the secondary endpoint. RFI and OS were also similar between the treatment arm. Other exploratory key findings were also similar to the original analysis, that is chemo benefited is beneficial for patients with the less than or equal to 50 years with a recurrence score of 21 to 25. If there are a score is 16 to 20, then if the clinical risk is high, then there is some clinical benefit. We have seen it is almost 3.1% for these patients with the low risk, with the high risk. And the new finding was that late recurrence exceeded early recurrence, and racial disparity is not for that event in the late recurrence. Thank you.
Thank you, Dr. Mohit. Very nice presentation and a very nice elucidation of how should we go about choosing our adjuvant treatment in hormone receptor positive HER2 negative patients. Chemotherapy is not for everybody. It's something that gets reiterated in this 11-year update of TAILORx. Of course, we have the RxPonder study also, where even in node positive patients, we can avoid chemotherapy. So the issue that I have in my practice is that I don't really get to do a oncotype DX of all my patients because of the cost constraint. So I think that is the same thing that you also must be facing in your practice.
Yes, sir. The cost consistency is always there.
Yeah. So suppose you are not able to do an Oncotype DX, and you have a patient who's a 45-year-old lady who has got a PT3N0, what would you do?
The hormone receptor positive HER2. So if the 45-year-old and I am unable to do the recurrence score, then I would like to offer chemotherapy for this patient. I might think about skipping anthracycline if the Ki-67 is less, say around. But I can't take only based on the take decision based only on the Ki-67. So I would like to offer chemotherapy. And what I personally feel that Indian population is, I think, different than the Western population. Here we are finding more of the young patient. You must also feeling the same patient. So I don't think that skipping chemotherapy without any proper evidence is a good idea for these patients.
So you don't resort to other methods of other recurrence score methods like the Indian CanAssist by OncoStem?
Sir, problem with these is that there, I think with the CanAssist there is some prospective data, but rest all the have so I don't want to graduate this personally. That's my personal opinion. You might or other my colleagues might be different.
Okay, and
I would like to do for Oncotype DX or Mamaprint, not other anything.
Okay, and suppose you have a patient who's a 6 centimeter disease after surgery, PT3N0, and she's a 45-year-old lady. What would you do then?
T3N0 means more negative, and Oncotype DX is available. I don't know.
Oncotype DX is available, and Oncotype DX says that the recurrence score is 14.
14, so it will fall into 11 to 25. That's the low risk. So based on TAILORx, I can think about skipping chemotherapy for this patient.
Actually, the problem is that TAILORx did not include, the patients more than 5 centimeter. They included only patients having a T size of 1.1 to 5 centimeters. So, of course, the NCCN says that such patients you can skip chemotherapy, but then from the TAILORx study, we don't have a very strong evidence for such patients because this is a 6 centimeter disease, and a PT3N0 we don't have a lot of data, even if you're talking about data, let's not include such patients. But then, yes, I think you're right. Then mostly we would like to skip if the recurrence score is 14. Mostly we'd like to skip, but if the recurrence score is more than 15, then I think we end up giving chemotherapy because of the MIND-ACT study that you also quoted.
Yes.
So yes, I think these are gray areas for us still because we don't end up doing a Oncotype DX for each and every patient. Of course, life becomes easy if we have Oncotype DX because we have TAILORx and RX Ponder to really guide us. But then we don't have that strong evidence with CanAssist, and we don't have that strong evidence with Mamaprint also. Of course, we can use these as one of the surrogate markers for Oncotype DX, but the data for how to really do the adjuvant therapy, be it chemo endocrine only or chemo endocrine, is something that with Mamaprint and OncoStem, that is CanAssist, is still a little obscure. Thank you so much for this nice presentation, and stay with us for the rest of the meeting. So after these two articles and the discussion on SABCS 2022, we would again come to the triple negative part of SABCS 2022 with Dr. Sahu. But before that, we have Dr. Vikas Talreja with us. Dr. Talreja, good evening. Dr. Talreja.
Hello. Very good evening. Very good evening.
Dr. Talreja is an eminent speaker and a name which needs no introduction. He is senior consultant at Regency Hospital, Kanpur, and he is going to speak about the recent advances in the management of HER2-positive metastatic breast cancer. Dr. Talreja,
thank you. Thank you for the kind introduction, and I request the organizers to share the slides. Systemic therapy in HER2 advanced breast cancer has seen a paradigm change, and I think it deserves very much mention. I believe no conference would be sufficient enough to see the journey as how the HER2 management has changed as we started our practice, and now how much it has advanced to it. And I really feel it is necessary that this topic needs to be discussed because, next slide, yes. So my topic will be outlined on the basis of the available anti-HER2 agents from 2018, since when we come into practice till now. The key clinical trials for selecting anti-HER2 agents, newer molecules that are up in the pipeline and knocking at the Indian shores are the tucatinib and trastuzumab deruxtecan. And what is the current treatment algorithm for the HER2 MBC cancers? And what will be our future direction for it? So if we consider 2022 till the latest study, uh, we started our journey in 1998 with trastuzumab being available. Until 1 decade of that, we had only one agent with us, trastuzumab. In 2007 came lapatinib, and that was a blessing in disguise. And then came pertuzumab 5 years later, 2012. And then came the TDM1 in 2013. And then there was gap of again a decade when we had neratinib, which wasn't much useful as into the clinical practice changing. Uh, till the time we in the recent past we have the margetuximab, we have the tucatinib, we have the TDXT with us. So HER2/neu has slowly progressed, but definitely progressed in a brighter direction as we see more and more options being available with us. Next slide. With us, and we feel that it is important that these options need to be discussed before we jump our practice from what is there. Next slide, please. And if we look at the mechanism of actions of various molecules, as we could see, trastuzumab being a very specific HER2/neu directed agent, pertuzumab being a biclonal agent, HER2/neu and HER3 actions, while we have antibody-directed cytotoxic ADCs being trastuzumab emtansine TDM1, which acts on the outer portion as well as the endo portion, that is the endosomal portion of it, as well as in the intranuclear pathways of it. Also is the lapatinib and the neratinib molecules based inside of them. Now, this was a decade back, but now we have molecules, especially next slide, please. Trastuzumab deruxtecan and trastuzumab TDM1, which have their ways of action different from the TDM1 and a multi-step action, as we could see outer blockade, inner blockade, intranuclear blockades. And therefore, if we have to summarize, we have to look at the ASMO guidelines for the latest treatment landscape for the HER2/neu breast cancers. So for early stage breast cancers, it is chemo, trastuzumab plus pertuzumab, as you could see from the slides. Next slide. Next. And if we look at the metastatic breast cancer, also in adjuvant situation, it depends upon the neoadjuvant response. You have TDM1 for those who have not responded with the neoadjuvant chemotherapies. For those who have responded to the chemotherapies, it's chemo plus trastuzumab plus pertuzumab. In the metastatic breast cancers, the first line is the Cleopatra, that's taxanes plus trastuzumab plus pertuzumab. In the second line, we have TDM1, and the third line becomes the game changer. So Caplaptra, trastuzumab deruxtecan, lapatinib plus trastuzumab, capecitabine plus neratinib, tucatinib, capecitabine, trastuzumab, lots and lots of options to consider. And where have these recommendations come, especially in the advanced breast cancers? Next slide. The first line, we have the Cleopatra trial, a beautifully designed trial, especially looking at the addition of the pertuzumab to the trastuzumab docetaxel combination, which was universal in there. And you could look at the hazard ratio of 0.68, meaning a 42% reduced chances of progression and a brilliant overall survival of 5 years of around 56.5 months. If you look at the 8-year survival data of these metastatic breast cancers, 37% patients were surviving with the triple drug combinations as double drug. Second line, again, we have lapatinib capecitabine combination being compared with the TDM1. That's the Emilia trial for all of us. Again, hazard ratio 0.75, 25% reduced chances of deaths, 30 months overall survival. And again, you look at those um, good overall survival margins. And these were those who were treated on trastuzumab taxanes combinations. And then we have Threxa for the TDM1 in the same patterns, again going up to the third line overall survival of 15.8 months. Now, Amelia definitely established TDM1 as a second line care. Next slide and next slide. The Theresa trial also established the TDM1 in more than 2 lines of therapies, as you could see. So TDM1 was with us with significantly improvement in the progression-free survival as compared to the physician choice of the treatment, which included either trastuzumab, lapatinib, or taxanes. And if you look at all these patients, the overall survival, again, if you look at the hazard ratio of 0.68, meaning a 42% reduced chances of deaths when you give TDM1 in the second line pre-treated patients, I believe that this drug is different to make. Now, also it is important as how was the response to this trastuzumab, or it was that was the PERTAIN study, which was specifically endocrine therapy in ER positive patients with trastuzumab. Again, you see the addition of the trastuzumab directed agent making overall survival impact into the same. We had abemaciclib plus trastuzumab. Next slide, plus fulvestrant versus trastuzumab plus the standard of care in hormone positive, HER2 positive, that is triple positive. And you could see there was an incremental benefit of 2.6 months of addition of abemaciclib versus the oral agents. And you could look at the overall survival also with the arm A that includes abemaciclib plus trastuzumab plus fulvestrant, being reaching a median overall survival of 31.1 months as compared to arm B with 29 months, and arm C as where on trastuzumab plus investigator choice of therapy was given, again dwindling around 20 months. So definitely it is important that what is clinically and radiologically obvious is also molecular wide obvious. We did an explorative RNA analysis of the intrinsic subtypes of luminal versus the non-luminal, and you could see they were intrinsically different. The luminal subtypes were associated with the longer PFS and OS as compared to the non-luminal subtypes with a significant hazard ratio of 0.5 and 0.68, meaning they were a different entity altogether to see. So with trastuzumab, TDM1 in the pipeline, we believe the game was over till we had newer anti-HER2 new agents. Next slide. Tucatinib was approved by FDA in February 2020, April 2020, and trastuzumab deruxtecan was approved by FDA in December 2019, and trastuzumab deoxychomazine or trastuzumab Seco-Duba was is still under the FDA approval, which again has an HER2 ADC-like properties. So tucatinib approval came by the HER2 CLIMB study. It was a phase 3 registration trial, and patients with CAP tucatinib trastuzumab combination was given. And why this combination was given? Because intrinsically it was believed that tucatinib is a HER2 specific TKI, which has 1,000 times more specific HER2 action as compared to the EGFR action, and with that selective action, it has an intracranial efficacy for it. And therefore, the trial intelligently included all those patients who were having an untreated brain metastasis, not needing immediate local therapy, or there was a previously treated progressed brain metastasis, not needing an immediate local therapies. And that's where I believe this was a game changer, because all the brain metastasis, next slide, patients were included at the baseline for all patients. All the patients, the brain MRI was done, and they were also used as a response of intracranial activity of this tucatinib drug, which was given. So tucatinib being a very simple drug given in a 300 milligram twice daily fashion, trastuzumab, the practice we do, capecitabine was given slightly on a lower dose because tucatinib was combined with it. 1,000 milligram per meter squared, day 1 to day 14, twice daily regimen for the same. And look at the overall survival curves of it. Again, next slide. You could see Uh, Overall survival in the second line of the situation, if you see those patients with brain mets, the hazard ratio was significantly higher. So 42% reduced chances of death if you add tucatinib to the patients who have a brain metastasis intracranially, as compared to those patients who had a brain metastasis and were not given tucatinib. So median overall survival crossed the 1 year barrier there. And also, if you look at the risk of the deaths was reduced by 51% in the patients who were having an active brain metastasis, with a median overall survival of 20.7 months. And if you look at the adverse events of it, tucatinib combined with trastuzumab cap combination was approved by FDA for the treatment of those patients who even had a brain metastasis. Again, the TKI's addition had a similar side effect profile as compared to the capecitabine, so diarrhea, hand-foot syndrome, nausea, fatigue, vomiting, stomatitis, all these which were medical oncology amenable to it. Now came the newer blockbuster molecule, which is much hyped, much talked, and much discussed about, the trastuzumab deruxtecan. It is a novel HER2 anti-directed antibodies. It has Ig1 monoclonal antibodies with same amino acid sequence as the trastuzumab, and is linked to a combination of a chemo. I believe topoisomerase 1 inhibitor, that is um, basically an excipitant derivative, and a tetrapeptide based cleaver linker molecule. So you have Hrithik Roshan, you have Salman Khan, and you have um, Shah Rukh Khan in the same field, and that makes it a different molecule altogether because it has a payload mechanism of action which is having intrinsic chemo based, a higher potency of payload, a higher drug to antibody ratio, nearly more than 8 times of it. The payload with a very short systemic half life and a stable linker payload and a tumor selective cleavage and a bystander anti-tumor effects. So definitely this was a path-breaking news for it, and it, it looked at the responses of the Destiny Breast 1 study. So Destiny Breast 1, next slide please, was a study where you see the TDXT being used in all patients who had a previously HER2 positive MBCs, progressed on the standard lines of therapies, and looked at the swimmers plot of it. Everybody responded. So an overall response rate of around 62%, and those response lasting up to 18 months in the third line situation, I believe that was a standing ovation remark for it. And if you look at in the third line, the PFS of around 19.4 months, again making it a unremarkable molecule to challenge with. That trial pushed to take it into earlier lines of therapies. So Destiny Breast 3 was designed again a phase 3 trial where TDXT was head-on compared with the TDM1 molecule, and those patients who failed the first line Cleopatra situations were given of them TDXT being a simple molecule, 5.4 milligram per kg every 3 weekly, as compared to TDM1, 3.6 milligram per kg every 3 weekly. And if you look at the curves again, they were remarkable. So active molecule was compared with another active molecule, and I believe the more active version of it prevailed. So hazard ratio of 0.28, meaning a 72% reduced chances of progression when you give TDXT as compared to TDM1 in the second line situations. Next slide. And with that, I believe the median PFS reached up to 25 months as compared to the comparative arm when you give the TDM1 molecule where it was hovering around 7 months around. So definitely a joyous news to Astra, but definitely everything that comes does have its good share of side effects, and that was the ILD associated pneumonitis part of it. And therefore, based on the Destiny Breast 3 efficacy and safety data, ASMO and US guidelines updated TXT as a preferred option in the second line situations as compared to the TDM1. What works in blood also works in brain was the molecule inside. So if you look at the CNS activity of the TDXT with HER2 positive breast cancer patients with the brain metastasis, you look at the Tuxedo trial, you look at the Deborah trial, you look at the Duke trial, all of them, it shows that there was an intracranial response more than 70% in these patients with active brain metastasis, and 70% of these patients do had a active brain metastasis, showing that it does cross the blood-brain barrier and does have its efficacy intrinsically. So definitely a very active molecule and a very risky molecule also at the same time. So again, from 5.6, if you have to reduce, 4.4 and 3.2 are the dose reductions. Next slide, please. You have to look at the side effects, especially the dyspnea, fever, and any worsening of the cough. And you have to do a pulmonary function test, HRCTs, and bronchoscopies to confirm whether to rule out the infections. And if resolved in less than 28 days, you can resume the therapies. But if it is more than, then you have to reduce the dose. And steroids remains the main source of the treatment of them. And if you feel that the dose is insufficient, you should take a pulmonologist into the same account. Also, TDXT also has moderate hematogenic potential. So first cycle dexamethasone plus 5-HT, 3 receptor antagonistics plus NK1 only in selective cases should be given before the infusions. And the form for management of a late breakthrough nausea, probably olanzapine or metoclopramide does the good work of them. Now, also this molecule has been in number of clinical trials and is coming up and up in many of them. Another molecule that has very promising effect right now is the trastuzumab deoxychomazine, also known as the Seco-Duba combination, that is a DNA alkylating. Again, uh, very important molecule that to look forward to, especially in those who are HER2 low positive patients. So those patients who are HER2 low positive expressing patients, again, you the duration of response is lasting for a longer duration of time. The TULIP trial was designed for it to compare with the standard of care, where uh, you could see the next slide. Central reviewed PFS shows an hazard ratio of 0.64, meaning a 36% reduced chances of side effects. The molecule is given again every 3 weekly, 1.2 milligram per kg, and third line and beyond was the treatment protocol for him. So for HER2 positive stage 4 breast cancers, again, we have seen that the line has changed. The Cleopatra is the first line, but the second line we have now the TDXT ruling over the TDM1, and the third line again, tucatinib, capecitabine, trastuzumab combinations are there. And if you look at it furthermore down, also margetuximab, neratinib, two are coming in the later lines of situations. And again, Seco-Tuba is again a molecule to look forward to. To summarize, treatment landscape for all patients with HER2 breast and metastatic breast cancer is rapidly evolving. The magnitude of clinical benefit scales for approval of agents have improved. There are more efforts to implement patient-related outcomes, real-world studies to evaluate the effectiveness, and we have been integrating big data and moving from evidence-based to a real-life evidence-based medicines, and that summarizes my time. Also, I thank everybody for patient listening and love to answer questions. Thank you for taking us through this very elaborate presentation on the use of
Radha sir, your voice is not coming.
Hello, is it audible now?
Yes, sir.
Yeah, much better.
Okay. So I wanted to understand from you as to what is your experience with TDXD, if any, and once available, would you like to use it in the second line with the robust data that it has?
I've been using it on trial and off trial, and this drug definitely works very differently. The responses are absolutely immediately, and you could see patients responding beautifully. ILD is something which we need to be very careful because it sets in within the first or second dose as you infuse. And I believe prophylactic or preventive steroids is always best, because once sets in, we don't know how much it's going to take time. But yes, this drug is a game changer, and I believe in near future we will be having a direct comparison of the Cleopatra with the TDXT. With the remarkable intraocular response, I believe radiation oncologists are also going to get out of uh, job the way this drug works, because it has its way of action. It has a very unique way of the methodology as where the drug was built, and in real also when you give that drug you feel that it does make a clinically meaningful impact on the patients.
Okay, so have you used it in HER2 positive or HER2 low patients? Like which trial are you using it in?
So we have the Destiny trial open for our recruitment, and we have started recruiting patients for it. Also, there were patients who are not in trial who wish to be get it administered. They have been importing that drug, and again, all those patients where HER2 expression was initially high, or right now they are 1.9 or 2 positive, where you can't classify them as a fish positive, and still they are positive at the end of the day. So to new low section also, this drug does work its magic wonders also.
Yeah, right. And there is a trial, of course, like you said, ongoing between the comparison of Cleopatra regimen to TDX in the first line. We have to see as to what will be the results in the coming few months. Also, it is interesting to see as to how much will be the the prevention of CNS metastasis by using it in the first line, because generally these patients will develop CNS metastasis as the time passes by. So we have, suppose we have a patient who's upfront setting and does not have CNS metastasis, whether we are able to reduce the chances of CNS metastasis vis-a-vis a patient who is second line, third line, and having a florid CNS metastasis. There we have seen that the response rates are in second line to the tune of 60%, intracranial responses in third line to the tune of about 40-45%. So they are quite amazing, like you said. But then that also will be a very important point to consider TDX in the first line, if at all it is able to beat the Cleopatra regimen.
Still, the Cleopatra regimen is there to stay. But if we fail on Cleopatra, I believe TDXT should be offered unanimously to all the patients in trial or outside trial, because this molecule does have its efficacy intracranially and systemically also.
Because a very important point to remember is that the Cleopatra trial excluded patients of brain metastasis, or all those patients had to have a local radiation therapy.
Absolutely,
Right.
yes.
Right. So thank you once again for this very nice presentation. So
Thank you.
after Dr. Talreja's talk from one eminent speaker to the other, now we have Dr. Sahu with us, who is a name that needs no introduction. He is a senior consultant in Silverline Hospital, Bhopal. And sir, good evening. He is going to talk about the SABCS triple negative breast cancer takeaways. Sir, over to you.
Yeah, 1 minute just. I'm audible?
Yes, sir, you are.
1 minute. Why is my Zoom? Why is it going like this? Stop share. Let me just go in and share once again. Just give me a minute. Is it sharing?
Yes, sir. We can see the slides.
Okay. And is the slides, I'll make it full screen, and is it full screen? No?
Not yet.
No? Okay.
Sir, can I run from my side?
No, don't do it. I'll do it. Now is it full screen?
Yes.
Yes, sir.
Yeah. So thank you, Rajat, for the invite, and it was nice listening to Vikas. Good. I learned a lot from his talk, and in next 15 minutes or so, I'll be running fast. I've already been 15 minutes late, and I think I'll save some time for you. So I'll just, out of the 49 or 50 odd things which was presented for triple negative breast cancer, in the SABC, I picked up 4 or 5, which I thought could make some changes. There would be more in the abstract form, which I could not go through. But one of the trial which most spoken triple negative is the trial from our country, India, from Tata Memorial, which I'll be speaking in the last, and I will then find should it be used in every patient who comes to OPD every day for the neoadjuvant setting, or should we be using it for a select group? So that will be my mandate for today. So I start off with a study presented by Indian, but not from India. It is from the Mayo Clinic. Siddharth Yadav presented the population-based estimates of contralateral breast cancer risk among carriers of germline pathogenic variants in the ATM, BRCA1, BRCA2, CHEK2, and PALB2. Why I picked up this is because it is one of the things, as gradually we are going into more of the testing by NGS, we would find this mutations very, very commonly, and some of the mutations do have a familial impact, and it's a need of the hour to be aware of which does increase the risk of contralateral and also which has a familial risk also. So if you look into the carrier study published in New England Journal of Medicine 2021, it looked at around 32,000 odd patients, and it had an equal match as unaffected women as controls. And they looked at the pathogenic variants in each gene, and basically they looked at 5 of them: ATM, BRCA1, BRCA2, CHEK2, and PALB2. Just to make things very, very short, that there was the increased highest risk of the cancer to appear in the familial group if the patient had a BRCA1 or BRCA2, then it was PALB2, and then CHEK2, and then ATM, in that order. In this study, which I am going to speak about, is for the risk of contralateral breast cancer, for which we also do mammography every once in 1 to 1.5 years for patient of breast cancer on follow-up. So they took 15,000 odd patients, and the patients had to have a preserved contralateral breast, and that should be at least 1 year follow-up. And if patient had DCIS at diagnosis, at the initial diagnosis, they excluded them. They screened it for the 5 germline mutations which I just spoke, and they, on a time to event analysis, they compared contralateral breast cancer risk between carriers in each gene versus a corresponding non-carrier. They also would look forward to a multivariate proportional hazard regression analysis which accounted for competing risk of death, and the censoring was done at the last follow-up, or if patient had the gene and the doctor or the patient felt appropriate to do a prophylactic mastectomy, then the patient was censored for that time. And it was adjusted for risk for the contributing study for race, ethnicity, age and diagnosis, menopausal status, histology, hormone positive status of the first breast cancer, and the use of hormone therapy. So if you look at the patient characteristic of the 15,000 patient, the 62 years was the median age. Whites were predominant, blacks were 15%, postmenopausal status was around 3/4 of the patient, ER positive was correspondingly 3/4 of the whole patient group, and the ductal histology was around 80%, and adjuvant endocrine was used in around 45% of patients. Basically, at the median duration of 11 years, they found that the contralateral breast cancer, which is here indicated as CBC, was there in 801 absolute cases, and that is something that was there. In contrast, it was 711 for the non-carriers. So you had approximately 90 odd cases more in the patients who had this gene, which were known to increase the risk of breast cancer. So with the conclusion, I'll come to that and what they concluded. It was one of the largest study for contralateral breast cancer risk from population-based prospective studies. And the contralateral breast cancer risk in the germline pathogenic variant carriers increased more than 2-fold for BRCA1, BRCA2, and CHEK2. That means that what I mean to say is, if you find in our practice, we have always looked at BRCA1, BRCA2, but I think now CHEK2 also becomes an important thing for patients of a breast cancer. If you find that and you are looking into that genomic pathogenic variant, then you should be looking and more careful towards the opposite contralateral breast cancer. The risk increases by more than 2-fold. For ATM, there was no risk that was found to be increased. For the PALB, for the pathogenic variant, only for the ER negative group, it was increased. For the hormone positive group, it did not increase. It was thought to that probably the adjuvant endocrine therapy was having an effect on the fact that it did not and was not found to be positively, had the odds ratio was not higher for patients with PALB who are ER positive on endocrine hormone therapy adjuvant. So the black versus the white, there was nothing as elevated risk and they looked similar. The risk was similar, but one more important thing, for age and menopausal status, the risk was only seen in the lower age group and for patients who are premenopausal. Once they attained a menopause, the risk for a contralateral breast cancer actually goes away. Limitations, number of events were small in some of the subsets, and the race ethnicity analysis only is limited to black and non-Hispanic white women. We do not know, and we do not have the Indian Asians or what we tell as Asians. Lack of comprehensive treatment data also was not there, but with all said and done, what I take home is, if we are going forward and doing the genomic testing, as BRCA has generated interest in that, we also get some reports on NGS for these other possible pathogenic variants of the mutations. We should be looking at this genetic profile for check to at least for PALB, for ER negative, at least we should be careful for contralateral breast cancer. So coming to the second one, which I feel is again in the neoadjuvant setting, all my studies which I tell today from now for 3 of them will be in a neoadjuvant setting. So I look in the I-SPY 2 trial for the neoadjuvant, and they look at the high risk HER2 negative. So basically this will include 2 subset of patients which are ER positive, HER2 negative or triple negative. So here what they wanted to look into is one more monoclonal antibody. Here they are looking at a fianlimab, which is a fully humanized high affinity monoclonal antibody that binds to and antagonizes the LAG3, which is the lymphocyte activation gene 3. So what is a LAG3? It is a cell surface molecule expressed on immune cells, including T cells. So what this does is it binds to the MHC class 2, the LAG3, and it leads to the inhibition of the T cell proliferation activation. So when this drug is given, the monoclonal antibody is given, the fianlimab, it blocks this LAG3 MHC class 2 driven T cell inhibition. So basically the T cell inhibition, which is normally done by the LAG3, is now inhibited, and these are usually co-expressed with the PD-1. So Pimab is the anti-PD-1 approved for treatment of NSCLC. All of us know that, and also for the cutaneous squamous cell carcinoma. And the rationale of combination of these two comes from that we all have seen the pembrolizumab data for neoadjuvant with chemotherapy. So what it really does is, we have seen that in melanoma, that if you combine these 2 drugs, there has been a good overall response rates, and even some of the oncological long-term data has been much better. And we do find a preclinical data that suggests a synergistic interaction between the anti-LAG3 and the anti-PD-1 therapies. So basically you have a preclinical data, you have the combination working better and synergistically in other tumor types also. So with that, this thing into concept, the trial was taken up for the neoadjuvant where tumors were more than 2.5 centimeters, HER2 negative, hormone, if it is positive, only they took the high risk hormone positive, that is MammaPrint high. And there was a control arm for this, which was Pacli 80 per meter square weekly into 12 doses. Remember this, because when I come to the Indian data, I'll speak about the dosing of paclitaxel. The second was the paclitaxel with the LAG3 and the immune checkpoint inhibitor as a combination. So you have a chemo plus a monoclonal antibody for the LAG3 and against LAG3 and the immune checkpoint. The other arm was, other investigation arm included the Pacli and the immune checkpoint alone. So these were 3 arm like thing. And what they did was, they also, these patients undertook 4 cycles of 2 or 3 weekly. A dose dense was also approved here, doxo and endoxan, and then the patient was operated, and then we wanted to look into the PAT-CR rates. So what is happening is, if you look into this part of the story, that there were around 50% of patients who were nearly triple negative. The node positive was around 40% of cases, and the median age was around 46 to 48 years. If you look at this data, if you combine the chemotherapy with the 2 monoclonal antibodies, what you do find that the immune checkpoint inhibition plus the monoclonal antibody plus paclitaxel, the PAT-CR was higher than if you use Pacli alone, and it was approximately to the tune of around 54 to 55%. So this is something that really stands out, that the addition of the dual targeted therapy to paclitaxel in the triple negative actually increases the PAT-CR chances. Then comes into that there was a 53 gene signature which was validated, that's IM print. And this gene actually looked into that if they were positive for the immune, that is for this 53 gene, if it was a positive score, then what happened is if this drug was used in combination with the immune checkpoint, then there was around 82% PathCR. So nearly everyone whom you give this combination in an immune positive patient will have a PathCR, which is your goal ultimately for a long-term survival, up in contrast to 35% only if you do not use this and only use paclitaxel. And how do these results compare? Look at the RCB score of 0 and 1. If you look at it, mainly the 0 constitutes 89% for the patient who had the combination immune checkpoint and the LAG3 anti-monoclonal antibody. But if you take only the immune checkpoint also, it was 84%, around 74% for this immune positive. So basically, if you use this immune signatures and if it's immune positive, then if you use this combination, nearly every patient is going to be having a RCB 0 or a 1, and predominantly it will be RCB 0. If you look at the adverse event, yes, you have to be careful. These are drug combinations which can go for immune-related adverse event little more than what we normally look into. There were 32% of all grade hypothyroidism, 21% of adrenal insufficiency or hypophysitis. There are around 5% of chance of developing type 1 diabetes mellitus. So what did I-SPY 2 neoadjuvant trial conclude? If you use immune checkpoint, and in this case, cemiplimab plus the LAG3 inhibitor monoclonal antibody, it's a highly effective combination in both triple negative breast cancer and HER2 negative, hormone positive negative breast cancer. The IM print signature, if it is positive, the chances of attaining a PathCR actually increases to 90% and beyond. And what happens is you have to look into the adverse event, which could be slightly more higher than what we normally see, but these are all manageable adverse events. Now we have come down to one more study very briefly. This was for patients who had this homologous recombinant deficiency, and they wanted to do the study of olaparib plus paclitaxel followed by EC in the neoadjuvant, or a carboplatin which replaces olaparib plus pacli followed by EC. So basically, we want to use a PARP inhibitor in this patient subgroup, which were homologous recombinant deficient patients, whom we normally feel that they do respond much better, but nothing has been approved in the neoadjuvant setting till now. So they used a pacli and ola followed by EC, or they replaced the pacli, the olaparib to carboplatin plus pacli followed by EC. The reason for that is olaparib was considered to be slightly better tolerated than the carboplatin in initial trials. So here the phase 2 data, and they are following up and giving us the follow-up of 50 months on the median. And this is the data which I spoke to you earlier. Again, this is 80 milligram paclitaxel for 12 weeks plus carboplatin AUC2 versus what you look at the olaparib at 100 milligrams twice daily. And it was a 2-to-1 randomization, a small study of 69 patients into the olaparib arm and 69 patients into the olaparib and 37 patients into the carboplatin arm. Majorly, the node positive was around more there in the carboplatin arm. If you look into the carboplatin arm, had more node positive than the olaparib, but it's a small trial. I want to look into that data. What it really stands out is, irrespective of in this subset of patient, whether you use olaparib or use a carboplatin, the PathCR in this mutated BRCA gene is exactly same. So basically, it tells you that the addition of a PARP inhibitor does not give more a PathCR. If you look at the brightness study, which was published few years back, it also gave us the same indicator that a PARP inhibitor in addition to carboplatin does not add anything. So basically, that is again being put forward that in the neoadjuvant setting, PARP inhibitors are not going to do much. But if they are a wild type BRCA with HRD score is high, here they took anything more than equal to 42 as HRD score. They found that the carboplatin arm was superior to the olaparib for wild type HRD score high. For the mutated, both were considered similar. So they concluded that the addition of olaparib did not add any advantage in contrast to carboplatin, and actually in the HRD high and the BRCA unmutated, actually a carboplatin superior, but it was a small trial. It requires confirmation by a bigger trial. But the message that's coming to me as an oncologist is, till now we do not feel confident and data does not support neoadjuvant use of PARP inhibitors. Now coming to the elephant in the room, that is the platinum to sequential taxane anthracycline data from TMH, presented by Dr. Sudeep Gupta. All of us know that. So I will just briefly take 5 minutes for this and then end my talk. It was a TNBC which was taken, and they took anything as a cutoff for less than 1% for ERPR, not 10%, mind you. They took anything less than 1% for ERPR negativity. There was no evidence of any metastatic disease. They are fit for anthracyclines, and they included anything from T1 to T4 from N0 to N3. They randomized to patient to platinum, Pacli carbo, followed by AC or EC, or a control was Pacli followed by AC, EC. Only thing is carboplatin was not there. And then they went for surgery, breast cancer mastectomy, then they went for radiotherapy. Mind you, here the difference starts. The carboplatin was used for 8 weeks, not 12 as we normally use. Yes, they use 100 per meter square, but the normal dose is 80 milligram per meter square, which is used for 12 weeks. Here they used for 8 weeks for 100. The second point what nearly stands out is most of the patients here actually took 3 weekly, not the dose dense actually, but although it was allowed for both. And if you look at it clinically, it was both eligible for premenopausal and postmenopausal. And as per PathCR, there was no use of capecitabine or not capecitabine. So the data, how do we look when capecitabine was not used for patients who did not achieve a PathCR, is something all of us have to take it together. Now the results, it was data which had a median follow-up of around 68 months. It was around 720 odd patients, 3 were taken out due to protocol violation. And this data had 70% nearly of patients less than 50. The peri or premenopausal was around 60% and the postmenopausal was around 40%. There was no BRCA testing done, which I did not find in the slides which I got. But the family history was positive for any cancer in around 20% in the control and 17 in the platinum arm, but there's nothing as a BRCA data. It was predominantly patients who are locally advanced. 60% were them who in Indian setting, normally what you see is a big locally advanced operable breast cancer. The clinical status, the positive nodes were around 90%. So that's something that is a very, very bulky disease than what we normally see outside India trials. Invasive ductal carcinoma was around 90%. The data told that with this study as it was done, there was a 14% delta benefit, and which was statistically significant in reports of PathCR. If you look at it in contrast to if you add platinum to not add platinum. If you look at the PathCR to breast, it was significantly more. Actually, the nodal PathCR did not much vary, and it was also not much significant, but the breast PathCR and combined PathCR was actually superior for the group of patients who received platinum. By age, if you have patient more than 50 or less than 50, more than 50, the difference just goes away, and less than 50, actually the difference was statistically significant in all patient subgroup, both if you take the breast plus node or breast alone or nodes. If you look at the event-free survival, intent to treat, the platinum was superior to the control. And if you look at it less than 50 and more than 50, the less than 50 patients, the use of platinum, the event-free survival at 5 years was around 74% versus 61. Mind you, if you look at the Pembro data, we have a 3 years EFS, which is definitely numerical higher, which is 10 to 15% higher than what we're seeing here. But here it's a 5-year. The Pembro data for the neoadjuvant is a 3-year EFS. So it was statistically significant, and in the elderly beyond 50, it was not significant. The overall survival with the data which we have again was showing a benefit for the patient who took platinum. In this group of patients who were less than 50, if you have more than 50, the addition of platinum in neoadjuvant setting did not add to event-free survival or did not add to overall survival. Again, the forest plot tells the same. If you achieved a PathCR, irrespective of the age group, you did benefit. That's something that comes into again, that if you can achieve a PathCR, you can do better than those if you cannot. So our intent, if you're doing a neoadjuvant, is to give the protocol in which you can achieve the best PathCR. The tolerability was okay, and the compliance was also not different. So they concluded the addition of carboplatin to taxane anthracycline neoadjuvant chemotherapy should be the standard in treatment with TNBC who are less than 50 or who are premenopausal. The word it is important to highlight is should be the standard, means they advocate for everyone. So let's come down to what the world data is all about and where I look this trial may be criticized. The data, what we normally look in the standard of care is now the Keynote 522, which used Paclitaxel, Carbo, and also used a doxo, epirubicin, endoxan skeleton as used here. But here, if you look at, they also added pembrolizumab across. If you look at the PATH-CR, here the PATH-CR is around 64.8% versus 51.2% for the chemotherapy alone. And if you look, go back to the PATH-CR, which is achieved here, it is around 41% for the chemotherapy arm. But mind you, this is a chemotherapy arm without. So I take this arm as the standard 61% in the Tata Memorial data for patients. But if you look at all patients, it is a 54%, which was seen exactly what you see in this data of 51%, which you see in Keynote. So what I mean to say is, if you look at the data and if you choose the patients irrespective of the age group, we have actually dot and dot the data which is correlating with the Keynote 522. But the addition of immunotherapy is adding another 13 to 14% to what was achieved with chemotherapy. And this chemotherapy arm was exactly what was used in Tata Memorial Hospital trial. So this is something that we need to remember. So my take on this is, did the 8 cycle of taxane versus 12 weeks of taxane, did it make a difference, or is it a substandard taxane dose? Rajat, I'd like you to answer this when I complete this. This is one of my last slides. Dose dense chemotherapy is something which we always have started to consider is to be a now a standard. We know that this is a better way, and also we know that the dose dense also should and do better in terms of responses. And in era of immunotherapy, where does this regimen stand? So means that should I be offering it to every patient irrespective of the pocket? If it is 40 years, should I be not using immunotherapy and only using a Paclitaxel, Carbo and anthracycline, or should I be also adding immunotherapy as 522 told? Last, I-SPY type protocol, if it stands the test of time, should then the data not be shifting towards a double monoclonal antibody and a Paclitaxel carboplatin combination if you want to neoadjuvant, because you are going to then achieve a PATH-CR beyond 70 to 80%. And last, which I did not cover, the metastatic TNBC, if you look at it in the low type, because previously we all considered only 3+ or FISH positive to be HER2 positive. So if someone is triple negative and the HER2 is 1 or 2, and if it is 2, it is FISH negative, I think now deruxtecan does come in with the data of the low HER2 new setting. So with this, I stop here, and I would like to take any questions or suggestions, but that is what I did take of the trial, which I feel can change our practice, and definitely TMH trial would change our practice because most of my patients at least cannot afford immunotherapy. So if the take home for me till now was I never used to add carboplatin. So now I will definitely add carboplatin to my patients. But the point is, if it is a premenopausal, should I be excluding immunotherapy? That for me, I think it is a long take. I will still give immunotherapy, but because that take gives another 15% more advantage in PATH-CR. Rajat.
Right, so thank you so much for dissecting out the very nuances of all the articles that you presented. So I was quite sure from the very beginning that most of the discussion is going to be on the TMH study. In fact, I had reserved this question for you as to why 8 cycles and why not 12 cycles. So there are a few points that I have in mind regarding this study. One is about the 8 versus 12 cycles. Why was 8 cycles chosen? Because to my mind, there is no such validated regimen as 8 cycles. The other is that what can be the possible reason for the effect to be there in premenopausal and not being in postmenopausal? I was interested in seeing as to whether the compliance was a little better in premenopausal and not so good in post.
No, it was not. It was not.
Okay.
It was equal. It was equal.
So, but have they given the?
I had a slide. Okay, actually, I had a slide for that, and and the slide clearly showed that the compliance was the same actually. Okay. So that's clear. That's clear in the data.
Okay, okay.
So the compliance was not different.
So I think we'll have to ask the investigators as to what could be the possible reason for that. And the other is that I think one answer I can probably think of
This
the
one.
question.
This one.
Sir, it is not moving. This is the other slide that I am seeing right now.
1 minute. Now you're able to see that?
No, it is still, yes,
Yeah.
yes.
So
So-
this is there. The treatment compliance and toxicity were not different in younger and older patients.
Okay, right. So one thing I can understand is that this trial doesn't really tell us to not give immunotherapy in the neoadjuvant setting. It just tells us that in a resource constrained setting like our country, if we are using only a taxane an anthracycline combination versus a taxane platinum and anthracycline, a platinum added in younger patients is going to do better for those patients, is what
Yeah.
I understand.
So I think that the take home should be the same, that the standard of care should be immunotherapy plus a platinum and anthracycline combination. That's point number one.
Because to put it very simple, the experimental arm of this trial was the control arm of 522.
Yes.
So the 5522 built upon this particular experimental arm of the TMS study, and it further showed that a 13 to 14% benefit can be more benefit can be achieved by adding an immunotherapy. So I think that part is settled. But then why 8 weeks versus 12 weeks? And sir, like you said that you will be using now it in the premenopausal age group. I also am compelled to do that. But then when you will be using it, will you be using 12 cycles or 8 cycles is what
I will be using 12 cycles. I will be using 12 cycles. That's for sure. I would not change that.
Okay.
Because if you look into the 522, the PathCR is 51%. Here is 54%.
Yes,
So
yes.
it does not make much of a difference. So I feel I would not divert from that. But
Right.
I think they did it because to shorten the duration of the therapy. That's what I feel. That could be the only one reason that could be there.
I have the only experience that I have of using a Paclicar followed by EC or AC is the 522 regimen that I have given to about 4-5 patients till now. I have seen that in the Keytruda plus weekly Paclicarb phase, when the patient is taking, patient has got more fatigue. There is more of diarrhea, which can happen, of course, because Keytruda being included, and we do know from the trial also. But then it still remains to be seen whether a Paclicar followed by AC will be tolerated as well. That still remains to be seen.
But even the 522 had the same thing. No? They followed it with the EC in the later part of it.
Yes, in the later, but yes, I'm saying that when I am giving it with Keytruda, I see that the tolerance is a bit of an issue. Now without Keytruda, when we'll be giving patients who are not able to afford Keytruda, what exactly will it be? We'll come to know once we start using it. And we
but one thing is very clear with this, that gradually we are shifting to and accepting carboplatin in the neoadjuvant setting in the triple negative. That's for sure.
Agree. That is a very compelling evidence, and one cannot really ignore this right now. That's absolutely right, sir. Thank you so much.
Thank you, Rajat. Thank you, Rajat.
Thank you so much. Thank you. So after this, we go on to the next part of the webinar, which is going to be on the effect of Crixana and the use of Crixana in the setting of metastatic breast cancer, hormone receptor positive, HER2 negative. And to talk about this particular topic, we have with us Dr. Vikas Goswami, who's the Director of Medical Oncology at Max Hospital, Vaishali. Sir, good evening.
Hi Rajat, how are you? Good evening.
Good, sir. I hope you are well.
Yeah, all good. So am I audible clearly? Because I'm in a car.
Sir, very clearly, more than
okay, fine. So would your organizers be moving the slides, or should I be sharing my screen? Okay, slides are there. Yes, fine, yes. Good. So not a new topic. We'll be discussing about the role of Crixana, that is ribociclib, in the metastatic breast cancer setting, and we'll be trying to analyze how it stands vis-a-vis the competitors, which is palbociclib and abemaciclib in the metastatic setting. Next slide, please. So so we know that CDK4/6 inhibitors are approved across the guidelines, whether it is ASCO, ESMO, or NCCN. Next slide. And we also know that hormone alone given develops resistance in metastatic setting, and the pathways for that are primarily cyclin B1, PIK3, HER2, FGFR, and ESR1. So out of them, inhibiting of CDK4/6 is an ideal approach, at least in the first line setting, though in the subsequent lines, we are now trying to find out biomarkers to decide the second line therapy. Next slide, please. So we have overwhelming evidence that combining CDK4/6 inhibitors with endocrine therapy do overcome the resistance and provides longer survivals. Next slide. Like I mentioned, that we have various levels of evidence in favor of CDK4/6 combination with hormone therapy. Next slide. So the question is that we have for advanced breast cancers, ribociclib, abemaciclib, and palbociclib, and the next few slides kind of build up a case in favor of ribociclib as to how and why between the three, though we don't have a direct comparison, which one should be selected. So ribociclib exhibits more selective CDK4 versus CDK6 and more available to penetrate into the tumor cells. Next slide. So it is the only CDK4/6 inhibitor to demonstrate significant overall survival in the 3 trials. So while we can see that there is overall significant survival benefit in MONALEESA 2, 3, and 7 in favor of ribociclib, abemaciclib did show overall survival benefit in the MONARCH 2 trial, but the combination arm was fulvestrant, and MONARCH 3, the survival results are pending. PALOMA 2 and the palbociclib didn't have the overall survival benefit. And even in terms of number of patients, if we see ribociclib across all the trials has the largest number of patients. So certainly significant overall survival benefit in favor of ribociclib. Next slide. Now ribociclib is also, we know that, very well tolerated. The specific side effect, if I talk about QTC prolongation, is seen in 6% of the patients. Rest all are neutropenia, diarrhea, increased AST, ALT. They are all manageable side effects. Neutropenia is more in case of palbociclib, and others are similar. And if we talk about abema, we have used it. We know that the most dose limiting side effect is diarrhea. So it does become quite difficult to manage, and though neutropenia is less. So amongst, and also there is a 5% increased chance of thromboembolic effects. So in terms of tolerance, ribociclib is fairly well tolerable. Next slide. And there is something called as the magnitude of clinical benefit score, so which is called as the MCBS score. So this is also high, and this is required for approvals in the European societies. So here ribociclib scores fairly high with a score of 4 or 5 in MONALEESA 2, 3, and 7. Next slide. So the question is that the standard practice is that we tend to give chemotherapy in patients with visceral metastasis and also sometimes heavy burden disease. So should we be doing that, or should we be changing our practice? So the next slide will answer that question. Next slide. So this was a large pooled MONALEESA trial analysis, which confirms consistent survival benefit of ribociclib plus endocrine therapy among hormone positive patients with visceral metastasis and heavy burden disease, which is more than 3 metastatic sites. We can see the curves and the hazard ratio, which is 0.73 in favor of the hormone therapy arm. The next slide. So, of course, it was fairly well tolerable and no new safety signals were observed. Next slide. So the question is, what if the patient presented with symptoms of aggressive disease except visceral crisis? Would you consider Crixana plus AI over chemotherapy? And what is the evidence of Crixana plus AI versus chemotherapy? Next slide. So here again, the right choice study aimed to evaluate the efficacy of ribociclib plus AI versus combination in pre-menopausal patients with aggressive disease in first-line setting, and amongst the inclusion criterias, apart from the standard criteria, were symptomatic visceral metastasis, rapid disease progression, impending visceral compromise, and markedly symptomatic visceral disease. Now, these are clear-cut patients who, as per standard understanding, would require a chemotherapy. They were randomized into 1:1 manner in ribo plus letro versus chemotherapy. The chemotherapy was docetaxel, capecitabine, paclitaxel, gemcitabine, capecitabine, and vinorelbine. Surprisingly, what I thought, I don't know if the other regimes are also there, the carboplatinum is missing in that. And the primary endpoint is PFS, and secondary endpoints are all as shown on the screen. Next slide. And here again, with a hazard ratio of 0.54, there is clear-cut PFS benefit in hormone therapy plus ribociclib versus the chemotherapy arm. Next slide. So again, not only that, overall response rate and TTR was similar between ribociclib versus the combination arm. So one theory is that chemotherapy acts faster. However, over here, if we see the clinical benefit ratio, response rates, and time to tumor regression, all of them were similar. Next slide. And of course, safety profile, it's a fairly well manageable drug combination. Next slide. So to summarize, is ribociclib a rational first choice for addition to endocrine therapy? The points in favor are it has shown consistently overall survival benefit, even in visceral crisis, manageable side effects, quality of life is very, very good, and certainly PFS benefit is there. Next slide. So again, the same summary that ribociclib has robust data in its favor, not only in normal population of metastatic patients, but also in patients with heavy burden disease. Next slide. Thank you. With that, I conclude. Over to Dr. Rajat. Dr. Rajat.
I think Dr. Rajat has left, or
no problem, ma'am. So I think with that, I conclude my presentation.
Thank you, sir. Thank you for the wonderful presentation. Mahima, can we take the floor forward?
So now I would like to invite Dr. Amit sir for the next presentation, sir. So it's over to you, sir.
Yeah. Okay, so good evening, everyone. So I think so this is the last presentation and most people have left, but still, I I will just discuss quickly and will not waste much time. Regarding the management in the case of early breast cancer, the topic given was about HER2 positive, and especially with reference to TDM1 and what are the newer things which are being coming and how to adapt the response, especially in early breast cancer in this group of patients. So the agenda will be basically about this adjuvant therapy in the HER2 positive early breast cancer, whether it's a low risk one or when to cause it's a low risk and when to cause it's a high risk HER2 and when adjuvant according to them. What is the extended adjuvant therapy? What further can be added to this therapy, and the new adjuvant and the post new adjuvant in this group. So just we'll have a brief, like an adjuvant therapy. Since you say a 61-year-old female presenting with a 2.1 centimeter node negative. So this is a grade 2 tumor with hormone receptor positive. So that's most like a low risk HER2 positive tumor. And the NCCN, the latest the guideline which has come 2 days back, has also suggests that it's only for these tumor you have to give adjuvant chemotherapy along with trastuzumab, and endocrine therapy can be added if the tumor is more than 1 centimeter in this group of patients. So what the earlier data has shown, if the patient with even with the early disease, that is T1A disease, that is less than around 1 centimeter disease, if there is a elevated risk of recurrence in the patient with HER2 positive. So the event rate is something in the HER2 positive is 5-year disease-free survival is 77% if they are HER2 positive, otherwise it's 93.7%. And distant relapse-free survival is also high, something around 86.4% in this HER2 positive as compared to 97.2% with HER2 negative. So relapse-free survival in this group of patients. So in this patient, the treatment goes with the APT trial. That is only you have to give Paclitaxel and trastuzumab if the tumor size is for we'll say small, less than 3 centimeter node negative disease. And now the 7-year data has been also available with this drug, which shows the 7-year DFS increases to something around 93%. If you are giving Paclitaxel and trastuzumab, which is Paclitaxel weekly for 12 weeks and trastuzumab for 9 months, 3 weekly. So this for low risk HER2, the adjuvant goes with APT trial. Mostly we can use this with the better, and it is a hormone receptor positive, which is further improved to 94.6% as compared to hormone receptor negative, where it is 90.7% in this group of patients. So the other patient, which we say, so this patient has started therapy with Paclitaxel and trastuzumab. The other study, which has been the role of TDM1, that is the trastuzumab in this case, I will say for stage 1 HER2 positive breast cancer with node negative, with a normal ejection fraction and without no prior invasive surgery, we'll say for this new adjuvant, the TDM1 has been compared with Paclitaxel and trastuzumab and followed by trastuzumab again for 13 years with the primary endpoint with 3 years disease-free survival has been taken. And the follow-up is for 5 years. So this trial basically has shown in the TDM1, the events 3-year disease-free survival is 97%, whereas for Paclitaxel and trastuzumab, it is something around 92.8%. So there is a slight difference in this 3-year disease-free survival. And the number of events, we'll say, depending upon the size, is also very less in this group of patients as compared to that. But the important thing is this hasn't met his endpoint of basically the reduction in the toxicity. So the primary endpoint was 40% relative reduction in toxicity with TDM1, which hasn't, though the amount of, we'll say the neurotoxicity is less with TDM1 in this group of patients. Any toxicity requiring dose delays more or less similar in both the group of patients. And the other toxicities like congestive heart failure or decline in the left ejection fraction is also less in this, but still they are not so low that we can take TDM1 in this group of patients as a neoadjuvant one. Now coming to the adjuvant therapy, those with patients with in the adjuvant, those with a higher risk HER2 positive. So it's like a early age group, young patient, 44-year with a tumor size of 5.4 with a node positive disease, and though it might be ERPR positive and HER2 positive. So in this group of patient, if we say if there is a node positive, then adjuvant chemotherapy you have to add with trastuzumab, or pertuzumab is also can be added in this group if there is a node positive. One can find in this group of patient. So this is based basically on the affinity trial, which has taken pertuzumab, trastuzumab along with the chemo, along with trastuzumab and chemo in this subset of patients. So they have taken that in the case of invasive breast cancer, who are node positive or any tumor size or node negative more than 1 centimeter, at least tumor size has to be taken in this. So in the affinity trial, the benefit is only seen in the node positive cohort. Otherwise, in all other cohorts, this benefit was not statistically significant. And so the 6-year data is there. Now this 6-year the disease-free survival is 88% as compared to 84%. If you are adding pertuzumab in the adjuvant setting with the node positive disease. For the node negative, the hazard rate is 95% confidence is crossing 1 in this group of patients. So it is not found not to be significant. So the next is extended adjuvant therapy. So the patient case, we'll say if this patient comes to you 44 years with bilateral mastectomy and axillary node dissection with a tumor size of 5.4 centimeter and 6 out of 11 nodes positive. So this patient has received adjuvant chemotherapy with trastuzumab, pertuzumab and endocrine therapy. So the important thing is about this endocrine, you have to add an endocrine therapy in this group of patient, and extended adjuvant neratinib can be added if the patient is hormone receptor positive and in a high risk group patient. So they have got a high risk of reference. So in these group of patient, one can consider adding adjuvant neratinib, but this neratinib has been only studied with trastuzumab. So the data regarding post pertuzumab or addition or the post TDM1 is not available at present. So still adjuvant neratinib has got its role in this group of patients. And this has come from the XTNT trial, which has taken neratinib in comparison with placebo for HER2 positive breast cancer with who has completed adjuvant chemotherapy and less than 12 years before randomization and have a node positive disease or residual disease after those of the new adjuvant therapy. So the 5-year disease-free survival is something around 90% versus 87.7% in this group of patients. So the benefit again in this is mainly seen in the hormone receptor positive subgroup rather than the hormone receptor negative. It is 91% against 87% in this group of patients. So then this 5-year disease-free survival is further significant if the hormone, we will say the hormone receptor positive and less than 1 year from last dose of trastuzumab. That is, it increases to 5.1% benefit they show. And if it is without PCR, that is the patient hasn't achieved a path CR, in those groups, the benefit is much higher. That is something around 8%. So that there is the place where you have to add adjuvant neratinib in this group. Now coming to the neoadjuvant therapy. So just as an example, this is a 33-year-old patient with a palpated node under her right axilla. It's the IDC grade 3 with a hormone receptor positive and HER2 new ISC3 positive in this. So who are to be considered for the basically in HER2 positive for preoperative or the neoadjuvant? So the definite, so we are using is more than 2 centimeter, or those who have a node positive without any relation to the science has to be considered for neoadjuvant chemotherapy with trastuzumab and pertuzumab. But in clinical practice, more than 1 centimeter also with high risk feature, we can take those patients for neoadjuvant chemotherapy. So that has to be the thing we have to discuss in the tumor board and then plan accordingly. So the pivotal trial, which has led the neoadjuvant trastuzumab and pertuzumab, were the NEOSPHERE study and the TRIFENA, which has taken in consideration the addition of with paclitaxel along with a trastuzumab addition or trastuzumab plus pertuzumab addition, followed by surgery and then chemotherapy. Whereas in the TRIFENA group, it is also the FEC with trastuzumab and pertuzumab has been taken in consideration. So they have made that the neoadjuvant therapy, docetaxel, carboplatin, and trastuzumab, pertuzumab is the first line therapy which can be used, or AC followed by taxane, trastuzumab, pertuzumab can either be used. So these are the 2 drugs therapy which can be used in the first line. But the recent study which has come for anthracycline sparing, will say, is the phase 3 train data, which has taken the neoadjuvant chemo with or without anthracycline with dual HER2 blockade. So they have taken that of the docetaxel, carboplatin along with trastuzumab, pertuzumab, or then the other RAM with the FEC along with trastuzumab, pertuzumab, followed by the again 6 cycle of dosi-carbo, trastuzumab, pertuzumab, then surgery, and for 1 year of this adjuvant trastuzumab. So what we have seen with this study, that the path CR rate is similar in both the subgroup, whether you are using anthracycline or not using anthracycline. So in both cases, it is around 68%, and it is consistent across all the subgroups, whether it is any depending on the tumor size or the node or the hormone receptor or the age. So in everywhere, it is found to be more or less similar. So the event-free survival was not, there is no statistical significant difference whether you are using anthracycline or not. So thus that has made that you can also omit anthracycline in the patient with HER2 positive and just use docetaxel carboplatin along with trastuzumab, pertuzumab. So what after post-neoadjuvant therapy? So if a patient who have been treated with neoadjuvant TCHP regime after 6 cycle and had a lumpectomy and a node dissection, then now there is a residual tumor. So there comes with 3.2 centimeter and node positive. So in this group of patient, you have to add the TDM1, that is adotrastuzumab emtansine, and that is alone for 14 cycles. And if you have to discontinue it for any other reason, then you may add, then in that case, trastuzumab and pertuzumab to this therapy. So if there is a residual disease, so there comes the role of TDM1 in this subgroup of patients. And this data came from the Catherine trial, which has taken the trastuzumab emtansine, has been compared with trastuzumab as an adjuvant therapy, who had residual invasive disease in breast or axillary nodes after the neoadjuvant therapy. So this Catherine IDF invasive disease-free survival, for we'll say that TDM1, this is a distance thickness is reduced to something around 10.5 as compared to the number of events as compared to 5.9 in the case of the trastuzumab alone. So the number of 3-year disease-free survival is something around 88% as compared to 77. So there's an 11% clear-cut benefit in the disease-free survival with this Catherine data. And it is variable across almost all subgroups, whether it's a hormone receptor positive, negative, or in the node positive group, or the patient have previously received trastuzumab. So for the proposed strategy for managing any patient with a stage 1 or 2 to 3 HER2 positive, if it's an early, very early, that is T1A or B, in that case, you may go for a surgery with node negative. But in that case also, if there is a high risk patient, that is high risk is being defined as age less than 35 years, grade 3 tumor, hormone receptor negative, and a multifocal disease. So if this is there and the size is even small, then you have to consider for neoadjuvant therapy in those group of patients. Otherwise, for others, you may go for upfront surgery followed by trastuzumab-based therapy in all the group, in this group. So if they're T1C, that is something around, it will say around 1.5 centimeter tumors. So in those cases, you have to assess this again, the risk, and based on that, you have to further take the call. And for any tumor more than 2 centimeter or node positive, neoadjuvant, as I already discussed, with TCHP or ACTHP is the rule. We have to follow that. And then based on the residual invasive disease, if there's a PATCR, only trastuzumab, pertuzumab for a year. And if there is a hormone receptor positive, neratinib has to be considered, negative only then. Or if the residual invasive disease, in that case, TDM1 for 14 cycle has to be used in this group of patients. So this is the basically NCCN guideline, which shows a different regime which have to be used pre-operatively or operatively in this group of patients. The important thing is about the adverse event associated with HER2 targeted therapies. So for trastuzumab, pertuzumab, it is a cardiac toxicity which may occur, but should, though it's rare, but it occurs, and though they are reversible, so one have to be cautious about that. Infusion reactions are rare. Diarrhea may occur with this drug. With TDM1, it is the thrombocytopenia, transaminitis, neuropathy, and rarely the patient may have hepatotoxicity, cardiac toxicity, infusion reaction, we'll say mild bleeding the patient may presenting with. With neratinib, though we have got a limited exposure to that, though the diarrhea and rash has the important things which occurs along with liver and cardiac toxicity with this drug. So this is the one de-escalation. So how to modify according to the response adaptation. So the de-escalated neoadjuvant TDM1 plus endocrine therapy has been compared with trastuzumab plus endocrine therapy in hormone receptor positive patients. And the 5-year disease-free survival in this TDM1 group is 89%, and those with TDM1 with endocrine is 85%. And with trastuzumab, so more or less all are being same. The PATCR rate is though the highest with the TDM1 group, going up to 41% if you are using in the neoadjuvant setting in this group of patients. This is a phase 2 data, but there is no difference in OS. The COMPASS HER2 in the PATCR, where they have used neoadjuvant THP regime and adjuvant HP in patient achieving peace. So this is a study in which stage 2 and 3 patients who are at least more than 2 centimeter or node positive. In those, the initial neoadjuvant therapy has given as THP, whether paclitaxel or nab-pacli you are using along with trastuzumab and pertuzumab surgery. And after surgery, if there is a PATCR, in those group of patients, radiation and endocrine therapy is only given in this if appropriate. But if there's no PATCR, in that case, the standard of care, you are giving either anthracycline-based therapy, AC or TDM1 was given. So these are de-escalation approach, which they have followed in this study in the case of hormone receptor positive patients. So The other is the Destiny breast trial, which has taken trastuzumab deruxtecan versus TDM1 as an adjuvant therapy. It has been compared in this Destiny 5. The results are awaited. The Compass HER2 trial, which is in further taking in consideration TDM1 in combination with tucatinib, as compared with placebo in the patients with HER2 positive early breast cancer. All these are patients whose disease at presentation has a residual invasive disease and a high burden disease at presentation. In those group of patients, so the final results are still awaited. There are few further trials for risk adapted. I'll say for the neoadjuvant, you may have an addition of immunotherapy like Atizo. The trials are awaited with CDK4/6 inhibitors in the case of the ERPR positive, where palbociclib is being done, and the TDXD Destiny 11 is another trial in which the direction has come in the upfront. Whereas Atizo plus TDM1 is the other in which immunotherapy is being used in the second line in the adjuvant setting. So to summarize, what we say for all patients with HER2 positive breast cancer, the availability of HER2 targeted agents has markedly and rapidly improved overall outcomes. For any patient with tumor less than 3 cm node negative disease, consider paclitaxel based on the APG trial. Neoadjuvant chemo plus trastuzumab for patient with HER2 positive EBC and a tumor more than 2 cm or with node positive disease. So for neoadjuvant, you have to be very sure that if the tumor is 2 cm or more, definitely, or node positive, definitely, but also high risk patient of any size less than, if it is more than 1 cm or 1.5 cm, you can also consider neoadjuvant in those group of patients. For adjuvant, the data came from Affinity that you may either use only pertuzumab, trastuzumab in the case for 1 year, or Catherine, the TDM1, if there is a residual invasive disease, and for the Extenet, which adds on the neratinib after the completion of the initial therapy in this group of patients. So with this, I'll end my talk. I'll open to any question if there is, or it's okay.
Actually, sorry for that for the Rajat Bajaj sir. Actually, he's stuck in network issue.
Okay, fine. That's okay.
Okay, sir. Thank you. Thank you very much for the wonderful talk. And we'll wait for 1 minute for sir. Otherwise, we'll bid good night to everyone. Gitika, has sir confirmed?
Wait, I'll try again, ma'am.
Okay. Okay, I think sir have a lot of connectivity issues. So
Sir, ma'am, he's disconnect my call
no issues. No.
for 1 or 2 minutes. Maybe he's coming or not.
Okay. Yeah, he's there. I think Dr. Rajat is there.
Hello.
Hello. So, sir, we
Yeah.
invite you for the closing remarks.
Yeah.
Yes, yes.
Yeah.
Hello, is Dr. Amit there?
Yes, sir.
Dr. Amit?
Yeah, good evening, Dr. Rajat.
Hi, good evening. Good evening. Sorry, I actually there was a connection error. I just lost 2 minutes of your talk in the last 2 slides. So I have a couple of questions to ask you. Thank you for a very nice presentation. What do you really resort to in the neoadjuvant setting? Do you use anthracyclines or do you use a regimen which is free of anthracyclines?
To be frank, presently we are using still I'm using anthracycline in most of my patients. So, but there is surely an option of anthracycline free regime, but both ways are okay. But it all depends depending on the condition of the patient. So if there is any doubt regarding his cardiac status, anthracycline free, but still in clinical practice, we are using anthracycline.
Hello. Yes.
Yeah.
So basically, there is evidence to suggest that if you're using anthracycline regimens, then there is a delay of the use of Herceptin, and that can lead to inferior outcomes. And also the TRAIN 2 study, where it was seen that there was not much benefit of the use of anthracycline. So I believe if we not use anthracyclines, it is appropriate at this moment.
Yeah, that's true. So the TRAIN 2 has clearly shown that anthracycline-free regime are equivalent to in this group of patients. So we can surely go away with that.
Yeah, and more so, I think there was a Canadian study which said that after the fourth cycle, from the fifth cycle onwards, if you're using Herceptin, then there are inferior outcomes. The disease-free survival was inferior. So that also is one of the reasons probably.
So if we are using anthracycline, we are not using upfront. The first line we are using mostly the paclitaxel along with trastuzumab, and then after 4 cycles after surgery going, then we are using anthracycline in patients. So the initial response we are seeing only with trastuzumab in this group of patients.
Okay, right. That is one. The other is that if you have a patient who you used a Neosphere regimen, or for that matter a TCHP regimen, and you get a YP-T1, T1N0, T1C N0. So would you like to change to TDM1, or do you continue with Perjeta and trastuzumab in these patients?
So no, so for the current data, I will surely counsel the patient regarding TDM1. If there's a residual disease is still there, if they are not willing, there's no issues. We can still go with trastuzumab, pertuzumab, but surely after discussing with the patient and giving them the option.
Okay. Actually, very rightly said. Catherine's study, even in the forest plot, shows that there's a benefit of T1 also when we are using TDM1 over Herceptin. But then many a times, as clinicians, we are really in a fix, because you have given Perjeta and trastuzumab both, and just for a 0.8 centimeter tumor, or for that matter a 1.2 centimeter tumor, you change. So it becomes difficult for us to convince ourselves as to what will we do if the patient relapses. So that is a little issue, because sequencing is something that is still a very debatable issue when we are using all these lines in the upfront setting.
Yeah, that's true. But PAT-CR is a PAT-CR. We are getting complete response, then only. Yeah.
Agree. And the last thing is that suppose you have a patient who has had a complete trastuzumab for 1 year, and then the patient relapses with a liver metastasis or 2 or 3 liver metastasis within five months of completing a trastuzumab regimen. So how do you take these patients? What is the regimen that you would like to prefer in such patients?
So surely if it is a 5-month duration, I'll ask them to for this next TDM1, if affordable, then going with that. If not, in that case, might be with chemotherapy again, a trastuzumab or a lapatinib capecitabine like regime. If it's only limited to liver, I think so trastuzumab rechallenge is also a fair option. But if not affordable for TDM1, then only.
Yeah, because the Cleopatra regimen was in patients where they had at least a treatment-free interval of 12 months. So I think that regimen may not be very suitable. But in the Amelia study, they took patients who were
6 months.
Less than 12 months, less than 12 months, and in fact less than 6 also. So I think TDM1 can be the way to go if cost is not an issue. Right. Thank you so much for the very nice presentation and being a part of this symposium. Thank you.
Thank you.
With this, we come to the end of the 2-day webinar on lung cancer and breast cancer updates. We have discussed in detail about what are the current regimens of treatment, what are the current guidelines as to how we should approach our patients, and what is the way forward in the coming few months. And it has been an enlightening experience for me, and I'm sure the audience also has learned a lot from it. I would like to thank all my speakers, all the faculty who were a part of this particular webinar, and they had a great role to play in making it successful. I also would like to thank the team at Horizons for in making a seamless experience for me as well as for other people. And I would like to also thank the sponsors for being there for us. So till we meet again, it is a goodbye from all of us, and have a great evening ahead. Thank you.
Thank you everyone for joining, and thank you, sir, for your kind remarks.